Bismillah ar-Rahman ar-Rahim. We'll start our panel discussion about Egyptian guidelines. Our moderator is Professor Omar Shaban, and we'll start with Professor Gamal Serour. Professor Gamal Serour, the president of the Egyptian Sterility Society, and he's going to address us about why IVF practice in Egypt needs guidelines and how adherence to these guidelines would perfect the IVF practitioners.
بسم الله الرحمن الرحيم. أهلا وسهلا بحضراتكم. الحقيقة this is a very important session. I just take you back in the history. On the 21st of March 1986, Professor Abulghar, who is sitting with us here, late Dr. Raga Mansour, and myself, we started the first IVF center in this country, and obviously in the region. And we delivered the first baby, Hibatullah, on the 25th of August 1987. That's after almost 15 months since we started our center. And during that time, of course, there were complications. At that time, we were using just the conventional stimulation, HMG, Clomid, and we had achieved at that time live birth rate of almost 7 to 8%. And we published this first publication about this in vitro fertilization and embryo transfer in Egypt in the International Journal of Obstetrics and Gynecology in the year 1991. And in that paper, we had shown that the live birth rate, our live birth rate was 7 to 8%. But also, we reported the complications which happened with us, including ovarian hyperstimulation syndrome, including multiple pregnancy and high-order multiple pregnancy. Now, as a result of the progress of science and as a result of the continuous medical education, which really was taken in this country with the pioneers of this practice, there has been a spread of this modality of treatment all over the country. And now, when we look at the centers which are there and practicing, there are more than 100 centers. However, we have gone further because of the development of science. And instead of retrieving a few oocytes, science had shown us that you can induce ovulation and retrieve larger number of oocytes, and consequently you have a potential large number of embryos, and consequently you can achieve a higher success rate. Furthermore, with the development of the cryopreservation technique, passing from the slow freezing to the rapid freezing vitrification and the ultra-vitrification methodology, then there is a higher chance that you make use of the good embryos rather than wasting them and putting them all in the uterus. And also in that study, which we published in the year 1991, we had shown that because many patients, they don't achieve pregnancy with their first trial, then there is dropout. Those who need a repeat trial, it dropped to almost only 60% of the patients. And out of those, only 50% of the 60%, they could afford to have another cycle. So the dropout was not only associated with financial burden, but was also associated with physical burden and psychological burden. Now, with the stimulation protocols and the retrieval of larger number of eggs, physicians became very anxious to have more eggs, more embryos, but this was at the expenses of development complications of ovarian hyperstimulation syndrome, which is one of the nightmares of the people working in this field. Now, because of the so many centers which have started, and we are practicing now this technique all over the country, it is important, as happens in every branch of medicine, that we should have guidelines which guide us, which is the right stimulation protocol, which is the number of oocytes which you would like to achieve, which is the number of embryos which we should transfer, and should we take consideration various factors which might affect the outcome of the pregnancy, because you and I know very well that what matters for the patient is not a positive pregnancy test, or is not a number of pregnancy sac inside her uterus. What matters for the patient is whether she gets a live birth rate or she doesn't get a live birth rate. There's no point that the patient gets pregnant 3 or 4 babies and then she aborts, or she develops prematurely, or children develop cerebral palsy, etc., etc. So I think it is important to have guidelines to direct us what to do, and these guidelines should be as a guide for those people working in this field. Some people would talk about legislation. Certainly the question of legislation is very difficult, and experience of all countries had shown that the problem with legislation, that when science develops and you want to change something, then you will need almost 10 years to change the law in order to implement the new regulation. And consequently, certainly well-studied guidelines would be very helpful in regulating the practice, and will be also of guide to those young colleagues who are embarking on this field. And therefore, the Ministry of Health in Egypt started this initiation by asking Professor Mohammed Yahya to formulate a group to look into the various aspects of assisted reproductive technology and try to put down some guidelines. These guidelines are not binding because they are guidelines. They direct you to the best possible practice, but of course it varies from one patient to another. And consequently, if you say, there is a guideline for, say, a number of embryo transfer, and I transfer more than the number which is present in the guideline, I will have to have my justification. Why did I do this? And this is the guideline for us. And also, it is important for the patient because we are increasing the chances of the patient to have a live birth rate. And that's why a group was formed, and they looked into a number of aspects of assisted reproductive technology, trying to put the guidelines. But certainly, these guidelines will be put for general discussion, for input from all colleagues, and all this will be taken into consideration. And as I mentioned earlier on, that to change a guideline is much easier than to change legislations. And that's why I think this is a good start. It is a good start. And also it is a good start to have a registry, because in these guidelines as well, which is being developed, then we'll have a registry so that we could have data. And as all of us know, no science can improve without data. So I would like to thank the Ministry of Health for taking this initiative. Thank you for being with us here today, and thanks the chairmanship of this session, and thank all my colleagues who participated in the hard work which was done over the past 9 months or so, around 9 months. But I would like to say that what we are offering is by no means is a final thing. It is always open for your input, for your suggestions, for your wisdom, and we sincerely hope that the outcome of such a practice would be beneficial to physicians, to patients, to the society, and to the science in this field. Thank you very much.